Yeah, good morning, good afternoon to you all. My name is Senche Efrim Kumi. I'm the AfroPHC Research Lead. I'm the facilitator for today's meeting. Today we have Dr. Bargar, who is a nurse midwife and epidemiologist. She obtained her nursing degree from University of Stanford, Master of Public Health and Midwifery from Johns Hopkins, and PhD from Boston University. She has provided pregnancy and birth care to pregnant women and their family for over 30 years, as well as acted as the director of 2 different midwifery education programs. She has taught in a variety of university settings, including medicine, nursing, and public health, and as well as done training with nurses and midwives in Malawi. Her research has focused on maternal morbidity and sleep in women's health. She has conducted a randomized clinical trial, a quantitative experimental study, and cohorts, case control, and cross-sectional studies. So she's an expert in quantitative research. So for those who have any question, please wait till the end of the presentation. You can either raise your hand or you can put your question in the chat box and she will answer all questions for you. And today's session 2 is in two sessions. One, after the presentation, we will either break into breakout rooms or the presenter will either share a screen with questions so that we can all answer. Thank you. So the camera, you can go ahead.
I'm delighted to be here today to talk to you about quantitative research design. As you know, I'm a nurse midwife and epidemiologist, and that is my contact information if you need to contact me. Today, we're going to contrast knowledge generating research with knowledge generating research with quality improvement projects. I think frequently people don't know what the differences are, so I'm going to discuss that, as well as the basic principles of all quantitative design methods of how do we design a study so it's valid and unbiased, and particularly going to concentrate on how you can design observational studies so it can approximate the design principles of randomized controlled trials. And how do we match our study designs to our study aims? And we're going to do that and have some exercises in the breakout rooms for that. We are also going to discuss the essential elements of the methodology section when you write up a research proposal, and then common problems with questionnaire development and administration. So what's the difference between knowledge generating research and evidence-based or quality improvement projects? Well, first of all, you start with your problem, and most problems follow what we call the PICO format of population, what's the intervention maybe, comparative group, and you do your review of the literature. After you've done the review of the literature, now you have to say, are there any real gaps in the literature or limited knowledge on that particular topic? And if there are, then you probably need to do a knowledge generating research project to fill in that gap in the knowledge. So then you develop your research question, and your methodology really comes from how much is known and not known, as well as many other variables, which we will discuss today. However, if your review of the literature says we already know exactly what to do, the problem is we're just not doing it. So there's clear evidence of what to do. The interventions are safe and efficacious. Then we do a problem statement of how come that's not happening in our particular setting that we're interested in. And then we conduct our gap analysis. We have to implement our plan and evaluate the success. So knowledge generating research usually is based
Sorry,
on
Mary,
some
if I
sort
can
of
just inquire quickly, are you moving through your slides? Because it seems to be not moving on our side.
The slides are not moving. I'm on the same slide.
Or
Can
you
you
are
see?
still on the introduction slide?
Yeah.
Okay, you haven't
No,
moved to the.
I'm sorry. I'm on the knowledge generating research slide.
Okay, I think if you just put your slide on slide view, you'll find
It's
that
on slide view.
I think somehow we've got a version that's not quite on slide view yet.
Okay.
I think if you
No.
just check on your settings on your side, maybe there's another version that's, it says quant presentation.
Okay, so this is where I'm at.
Perhaps if you put it on slide view, we'll probably pick it up now. I think you're moving along.
Let me try a different way to put it on slide view up here.
Yeah, I think if you, yeah, there we are.
How about that?
Yeah, that's fine. Good enough.
Yes? Okay,
okay.
Sorry. Okay, so we're here on this slide, and knowledge generating research is usually based on some theoretical construct, whereas quality improvement projects use some sort of change model as their background to conducting the research. And so it's not always so clear cut as this, it makes it sound, but it is important to be try to be clear about what kind of project you are doing, because the analytic methods are very different of how you evaluate success in a QI project versus in a knowledge generating research project. There are no p-values in quality improvement projects. There's no hypothesis. We already know what the right thing to do is. The big problem is changing people's behavior, which is a lot, I think, somewhat a lot harder than actually doing an original research project. So that's the difference. Are there some questions about that at the moment? I can't really see. I'll just try to put the chat box up. All right, so now I seem to, there we go. So again, just to show the generalizability, research is designed to be generalizable. Whereas quality improvement projects have a limited scope of generalizability. They're limited to the setting because every setting has different organizational structure, different culture, different barriers to putting something in place. But they can be written up as lessons learned, which are valuable for another person who might want to do something similar. They're going to have a different set of issues in their setting, but they can learn from what you learned. The role of theory, I just told you, in quality improvement, it's the program that's being tested, not the theory. In research, we're going to often use experimental controls, or we have a comparative group. Whereas in quality improvement, everybody gets the treatment. So it's a pre-post evaluation. Matching or control charts is the kind of way we analyze it. The assumption of benefit for research, we assume we don't really know which one is better. Is the treatment better or not? We would not be doing the research if we knew. With QI, we know and what to do. We're assuming our intervention is safe and efficacious for all patients, and therefore there's no need for informed consent. All patients should ethically be getting the treatment, whereas we need to do informed consent in research. because there's no promise of benefits. The goals of research sort of meet the investigator's goals, whereas quality improvement serves the organizational goals of the organization. So just to talk about where we can go wrong when we design a study. So there's this, we start with some truth in the universe, and we're asking a question about that truth. So that's our research question. And so our target population is the population for whom all this question applies. And we have a phenomenon of interest. Then we design a study. And so we design a study, and that ends up as our study plan, and the truth in our study. Now we can make inferences, errors of inference between what's in the universe and what's in our study. So that's one place we can make errors when we actually design the study. And we end up with our intended sample, which is, we're hoping is going to reflect this target population, but we could make a mistake in who we choose to bring in or exclude from our study. We have a phenomenon of interest when we decide on the variables that we're going to measure, look at, and those may or may not reflect that actual phenomenon. So that's another place we can make errors. Then we implement the study. So lots of things can go wrong in our implementation. Our measurements can be off, the scales we use, the blood pressure cuffs we use, our lab measurements could be off. Lots of things could be off when we actually implement the study. And then we have our actual subjects. So all along the way, we can make inference errors. So we just need to be sure about that. So hopefully at this, everyone's seeing a picture of oranges at this point, and my slides are continuing to go. So the first clinical trial people talk about occurred in the 1700s by a ship surgeon named James Lind, and he did this trial because scurvy was a huge issue on merchant ships as well as Navy ships, that the sailors would develop scurvy, get very sick. Many of them died from it. And so he designed an experiment. And in that experiment, he chose his population. He had 12 sailors who were with scurvy, and he divided them up in pairs, and he paired them according to their symptoms, so that each person and each one had similar symptoms. It took place on this particular ship, and he had 6 treatments that he gave to each pair. He had a theory that this had to do something with acid. So he gave apple cider to one group, vinegar to another group, mustard and garlic purges to a third group, 2 oranges and 1 lemon to one group, another group, whatever elixir of vitriol is, and seawater to the last. And he made sure all of them were fed the exact same diet. And it's not clear what the time period was, somewhere around 7 to 14 days that he gave these things to these sailors. And he then observed what happened to them. His writings are not very clear, but the 2 who got the oranges and lemons got better, even though they ran out of, I think, some of the citrus fruit before the end of the study. And I assume the rest of them either died or or got sicker, something, but we don't know. So in a real experiment, we have observations that we measure, and in a typical clinical trial like this, we do a very simple relative risk to find out what the outcome is. We don't have to do any fancy statistics. We don't need any computers. If our baseline characteristics are equal, we just say what proportion got better in one group, what proportion got better in the other group. Easy. So very straightforward. So what's the meaning of control in randomized clinical trials? So we want to rule out all threats to valid inference. So we want to eliminate as many sources of systematic bias as possible. And so we're going to control the situation or the environment of the experiment. So we try to have very strict conditions. We want to make the groups as equal as possible on their baseline characteristics. So this is where we want to get a balance between inclusion and exclusion criteria. So in RCTs, they're very strict about who can come into the trial because we want the people to be as similar as possible. So when we randomize them, we hope that we distribute known and unknown characteristics randomly. So that's the key to randomization, and also, but to inclusion and exclusion criteria, is that we want to make sure everyone is equal on baseline characteristics. So we determine who gets a treatment and who doesn't by randomization. We use blinding to reduce treatment and outcome assessment bias. So if I am a physician and I know my patient is getting the treatment, I might do other things to make sure they get better than if I know they're getting the placebo. Just unconsciously, I might do that. And the people who are seeing whether the patient is better or not, if they know they were in the treatment and they really want this treatment, they think it really works, they might also be biased. So we try to make whatever we're measuring as objective as possible, but also to blind the people to what the treatment of the person being measured is to prevent that bias. So we eliminate valid inference by design. So that's what we've done in using those principles we use in an RCT. We try to control factors that can affect outcome, like change behavior, like Hawthorne effect, by using a placebo. So if everyone is taking a pill, then I'm not going to think, because I'm not taking a pill, I'm not getting better. We know that the placebo effect can be quite strong. So we use usually a placebo or some sort of attention equal behavior. So if one group is getting a group therapy, the other group is doing something else as a group, but not therapy. And then if there end up imbalances on baseline characteristics, we can control for those imbalances statistically. So, I mean, when we flip a coin, we don't always get 50-50 heads and tails. So sometimes we get bad splits and we have to then do some adjustment. But if you've got a great split, you don't really have to do much. So these are the three characteristics of all studies: comparability of populations, comparability of information, and comparability of effects. And I think if you keep that in mind, you won't go wrong. So in an RCT, comparability of populations is through random assignment, the consort figure, which we look for dropouts, because if a lot of people drop out of one group and not the other, now we've destroyed that baseline characteristics being similar principle. And so that can be a problem. And then we look at our table 1, which I'm going to show you in a minute. to see if there was a good split, a good random split. In comparability of information in RCT, we do double or triple blinding. So that's how we make sure that the information is similar across the board. And then for comparability effects, we use the placebo or attention control. And then we usually ask people don't do other treatments. So those are the 3 comparabilities in an RCT. And if you understand those, then those can be translated to observational studies. So here on the left, you can see is a typical consort guideline where how many people were randomized. They were allocated to a control and an intervention group. This is low back pain. Nobody lost to follow-up were 3 and 2. Discontinued the intervention. There was nobody. They did intention to treat, which is the right principle. They included the people who were lost to follow-up. So they included them in their analysis. And here is their baseline characteristics. And you can see that they were similar in age. And this group had a little bit more men than women, okay? The prognostic factors were very similar, age of onset very similar, duration a little bit longer in this wet cupping group. And these were measures of pain scores. So this had a little bit more, but none of these are drastically different. So we could look at that table 1 and say that, yeah, that their baseline characteristics were pretty equal. And that's a way to assure yourself. The same can be done with observational studies in table 1 to see how different they are. And usually they are different in observational studies, which is to be expected. There shouldn't really not be any p-values in a table 1 because it's not a hypothesis. The data is what it is. People are who they are. So you're just looking as a reader to see that, was the split pretty good? So the first classic observational study, many of you might be familiar with, was John Snow. The situation was that there was this cholera epidemic in the mid-19th century, and people obviously died. Cholera was a huge issue in many places at that point in time. What was unknown was understanding of bacteria and the role of sanitary conditions. People didn't know anything about that. So the questions were, how is cholera transmitted and how can we stop the cholera epidemic in central London? That was the question that John Snow asked. His hypothesis was, he had 2 hypotheses. One, that it was breathing the vapors from the decaying matter in the Thames, which was quite a dirty river, or drinking contaminated water. So, so what he did is he obtained death certificates from cholera. He converted those deaths into a map of where did the people live. And he looked then at the wind patterns and the distance from the Thames and the deaths, and there was no relationship. So that was a dead end. So then but then he did connect these deaths. If you can see them, there are these little spots. One small one is 1 death, and a longer one is several deaths. And then he looked at where they got their water. And there were no deaths at this workhouse where they got their water from a different source than the people who got their water from this pump. And there were none in this brewery that also got their water source from someplace else other than the company that supplied the water to this pump. And so he took off the pump handle and the epidemic went away. So that is one of the first observational studies. Someone has asked a question, I just saw it. What is better, knowledge generating research or quality improvement. There's not a better for one or the other. They both serve different purposes. So you can't say one is better than the other. It depends on what your purpose is. And if the knowledge is already there about what to do, then the goal is to get that knowledge into practice. So in some ways, that's really, really, I mean, it's very, very important for improving people's health. So there's not one better or not, but when you are starting a project, it is really the literature base and what's already known that leads you down one path or the other paths. Thank you for that question. I just saw that. Okay, so there was this strong correlation, and that's how was sort of the beginning of observational studies. So why do we need observational studies? Can people just put in, I'm going to give you a minute just to put in the chat. Why do you think we need observational studies? I see one response. Any other responses? So several people have said to collect baseline information. Correlate that information, okay. Provides information, especially in low-cost settings. Yeah, so that there are very real reasons, and cost is one of the most important reasons. But so now let's see if okay, so frequently it may be unethical or not feasible to do an experimental study. So it's, we can't assign people to smoke or not smoke. We can't assign people to use drugs or not use drugs. So in my area, which is maternal health, you can't really do a lot of experimenting with mothers who are pregnant. So we need observational studies for that very real reason. The other thing is randomized clinical trials don't frequently answer the question we want. So sometimes we do randomized trials, like in my area, but because it's not ethical, like to withhold certain pain relief, we have to allow people to go for the other condition if they want it. And so we end up also, because we have strict inclusion and exclusion criteria, and we're trying to see if something works, it's an efficacy trial, not an effectiveness trial. That is, it's not under real clinical conditions. Frequently you'll see, okay, we're going to study something in heart attacks or something, and the people can only have heart disease. They can't have kidney disease. They can't have diabetes. Well, how many people who have heart disease don't have some other chronic disease? Very few of them. So it doesn't really mimic real life in lots of ways. And the questions you might be studying are not suitable to an RCT. So if you have a rare outcome, you cannot do a randomized clinical trial, because if you have something that occurs 1 in 500, 1 in 100, you have to have a gigantic trial to see something even 1 in 100. And then there's complex, you know, these are complex processes. So they're okay for maybe a drug, but if you want to study something more complex like obesity, I mean, this is just showing you, you know, all the different things that contribute to obesity: international factors, national factors, local factors, homework factors. And I mean, it's very complicated. So that design is very difficult to do in a simple RCT. So we look at other kinds of observational studies. So how do we decide what kind of design to use? Does anyone have any ideas about that? One thing I just brought up was resources. So time and money, that's usually the biggest resource. If you're a doctoral student, yeah, you can't be a doctoral student forever. So you're probably not going to do a prospective cohort study over 20 years. So time and money is really important. Frequency of the outcome, as I just said. If something is rare, then we're not going to do even a prospective cohort study. We have to do some other design. And then access to data. Do we have access to data, and what's the quality of that data and the comprehensiveness of that data? These days in the United States, because of in many healthcare settings, everything's electronic. We have all these continuous monitors. A lot of people are not going to fund RCTs anymore. They're saying, you've got tons of data there. You can do almost a study as strong as an RCT using observational designs, and those are being less funded. So we have quasi-experimental, we have just descriptive. Sometimes that's all that's necessary. As someone said, we need baseline data. That's all you need to do, is describe what the problem is. Frequently, though, I've seen people do a study where they could have done some analytics with that study. They could have done something more interesting that could have maybe then given them ideas for an intervention. So you can sometimes do even more depending on how you collect your data.
Perhaps I could just add a quick comment, if you don't mind going
Yes.
back to that slide. Just quick comment to help people.
Absolutely.
I think in some ways, I think you come to the crux of the problem that RCTs can be very challenging. But I think you also posit the fact that you start with the RCT, many people seem to think that an RCT is all about drugs. It's large scale, very expensive, complex, and they sort of put it out of their heads. Or if they try it, they're naive about what it involves. And I think that in our setting here with the group that we have, a lot of them are beginner research who have not done any research at all. And I think that, you know, that having presented about RCTs, I would say your take home is that it is very doable, but be cautious about jumping into something that you don't quite understand well enough. So get to understand it better, but start with simple thing like a descriptive study. So we would be encouraging you to just do simple description, because in Africa, we don't have basic descriptive data, prevalence rates, or simple descriptions of simple things that are local and established as clear evidence of local. So you can start with descriptive studies. And yes, as I think has been said, is that consider in some ways some correlational stuff where you can say, would there be a correlation between this and that? But you've got to be very careful about how you take that step. And then you might go into other types of studies. So just think carefully before you, get confused. Think about your simple steps in terms of quality of evidence. I think you've got a question related to, Mary, the difference between quasi-experimental and interventional studies.
Right, we're going to get to that in just a minute. But the reason I started with RCT is that the principles, if you know the principles behind an RCT and keep those in mind, you can design a really excellent observational study. And so I agree with you that they can be done, and I've done them. And you can do them. And they don't have. It depends on what you're doing, how long it takes, right? But yes. So I agree, and we're going to talk about.
You're very right. It creates the kind of rigor of thinking that is really important, which I think is great. And I think sometimes, if I may, and maybe in the rest of the description you can bring that up, is many times people struggle with very more systems type of interventions. They want to see if a change can occur by virtue of something. And that kind of setting, maybe you can enhance or clarify how you try to create the intervention with systems type work, but still try to maintain the validity, integrity of that study. How that could be from your experience. Thanks.
Okay. All right. So we're gonna talk about quasi-experimental right here. So like an experiment, the aim is cause and effect, right? But there's no random assignment of subjects. Now, there can be random assignment by group or setting. So frequently you could, if you want to put something in place, you don't have the resources to do it in all 3 clinics at once. So you put them in one clinic, do it in one clinic. So now you have the other 2 clinics as your control. And then you could, gradually put it in 2 clinics and then still have that last clinic as your control. Or you have, so that's one way, or you put it in a clinic, but you have data from that clinic for the year before you put the intervention in place. And now you can compare. And you're not randomly assigning the patients to show up the year before or this year. I mean, you're sort of assuming the patients are going to be similar in the 2 years. So that's one way. So control group compensates for the lack of randomization. So you do have a control group. Intervention is introduced in one group and not the other. Okay. And there are a lot of design variations. There's natural experiments, right? You have an earthquake, you have a disaster, you have something that happens, and you've had some data before, and then you can collect data after. Many people did this. They were already collecting information on people's mental health in New York City, and then 9/11 happened. So then they looked at the mental health data afterwards. You have non-equivalent control groups. So outcomes of a clinic before the new process. So that's not an equivalent control, but it's pretty darn similar. And then you can have time series. So interrupted time series is what they're called, where you have the effects of treatment are inferred by multiple time periods. For true time series, you have to have several, at least 3, usually 6 time periods that you've measured before the intervention and then after. This is a study that was done on the impact of hospital-wide hand washing hygiene initiative for hospital-associated infections. So it occurred over 3 years. So here is their sort of baseline. And they had, this is the number of infections and this is the hand hygiene compliance rate. And they had people watching people wash their hands. And so this was their baseline rate. They had 1, 2, 3, 4, 5, 6, about 10 observations. Then they introduced different things, a marketing campaign here, electronic module for everyone to look at. So they introduced a couple of interventions. And then they kept looking at, they did the same thing and it went up. And then they did they had a presentation to hospital leaders about how successful they were. And they had a lot of different measures. They measured how much hand sanitizer that was used in the hospital, different things. Then there was a statewide campaign. Then there was a hand washing certificate that you had to get. So this is a way that they measured over time with different interventions. So they introduced them at different times, and they use control charts, which is something that method you use to assess if your intervention. And so they got up to 91% of hand washing, everyone washing their hands when they're supposed to. So, you know, a very classic way to do a quasi-experimental study with your baseline data and then slowly introducing some initiatives and then assessing an outcome along the way. So observational studies, there's no manipulation or control or random assignment of groups. They cannot in and of themselves determine cause and effect. So we've got descriptive studies, simple descriptive studies, descriptive characteristics or behaviors of a situation, how frequently things occur. No, you know, that's might be what is actually needed, is a simple descriptive study. Analytic studies describe the size or the magnitude and the direction of a relationship. So you've got two or more variables, they're hypothesis generating, they may improve or inform health-related activities, they may inform decision-making, but you usually have a comparison between two groups. And the different kinds of observational studies, we've got cohort studies that follow a group over time. They can either start at one point in time and go forward, or they can they can look backward at a group once, you know, a period of time has gone, or they can go in both directions. Cross-sectional studies are one-time assessments. So we're only asking people at one time, rate your health, rate your how anxious are you, whatever. And so they're easy to do because they're one time, but sometimes it's difficult to know if the exposure came before the outcome in a cross-sectional study. Case control studies, we choose people who have the disease, and then we match them to those cases, and then we assess exposures that happened in both groups. So they are a little trickier to design, but very effective for very rare outcomes. Secondary data is a type of observational study. They can be any of the above designs with the data that you have, depending on how the data is collected. And meta-analysis is actually a type of observational study where we combine a bunch of study results to come up with a single estimate of effect. I won't really be talking about those today. So what are the issues related to observational studies? Anyone want to respond in the chat what you think those issues might be? What are the problems with observational studies? So I see the response is bias. bias, and more bias. Okay, so yeah, so you need to bias is a huge issue, right? So we have to think about that. Okay, somehow when I look at the chat that goes around. Okay, so I'm going to just talk about, if you want to, we want to look at the relationship between smoking and a health outcome, since we can't randomize if you smoke. So comparability of populations. So people who smoke are going to be different, right, than people who don't smoke. Their baseline characteristics will be different. They could be different, like more men smoke than women maybe in the setting. It's not necessarily true in the United States, but, smokers tend to have more mental health problems. So comparability of effects, they tend to use illicit drugs more often. Maybe smokers tend not to exercise. So the problem is, if we're looking at something, people self-select to do certain kinds of exposures. And so that makes them very different on their baseline characteristics. So there's confounding or bias because of that. And we need to now take that into account. If we collect the information on potential confounders, age and gender are the two most common, well-known, usually largest confounders, but there are many others. If we collect the information about potential confounders or covariates, we can control for them in our analysis if we're doing an analytic study. So it's a matter of making sure we have the information in order to do that. Comparability of information can be also problematic. So we need to make sure that we have objective measures that can't be influenced by the participant or researcher. We have to use the same source, like in some observational studies, case control studies, sometimes that if the cases are dead, they'll use a proxy respondent, like a spouse or a father or whatever. Well, we have to make sure that if we're using proxy responders, that they are giving us similar information that the person themselves would have given. So comparability, we have to work harder for comparability of information, but it is possible. So there are differences. So this was a study that was a myocardial infarction, death, and diabetes in twins with different BMIs. So we always think that, having a high BMI is a risk factor for cardiovascular disease, for dying from an MI, or makes your risk of death higher. So these researchers said, okay, what do we do? So they got monozygotic twins, identical twins. So now they have the same genetics, they have the same gender, the same age, right? So they've, by restricting their population to monozygotic twins, they've now got comparability of populations for all of those things. Comparability of effects, they collected a lot of information about socio-demographics, like, what was their work, how much money, did they exercise? This is done in Sweden, where they have a lot of information. But the information was collected at the same time with the same instruments, and they collected all that information. And then comparability of information for outcomes, they used the same database, Swedish database, so it was very equal. Interestingly, they found out that having a higher BMI was not a risk factor for dying or myocardial infarction, although it was a risk factor for diabetes. So this is, a way where you're choosing your population carefully, that you can get these comparabilities without, and this is something you couldn't do. You can't randomize someone to eat more and get fat, but they did this study, and it's a good example of how you can achieve these in an observational study. So someone asked about what's the difference between longitudinal and something else, longitudinal studies and that kind of thing. And so cross-sectional studies, one time at present. A prospective study is we get a group of people together and we follow them forward in time. So, we could do a lot of exposure. We can assess a lot of exposures and a lot of outcomes with that. But of course, we have to follow them. So they're time consuming, take a lot of money because we have to follow these people. We can't get very many dropouts. A retrospective study is where we identify a group of people, and then we ask them, we go back and assess their exposures from 10, 20, 30 years ago. And now there's going to be recall bias when we ask them, but if we ask them all in a similar way and hopefully use the similar prompts, we're going to get equally biased information so that it's not going to be biased in one direction or another, hopefully. Now, you know, we do these kinds of studies for people to look at babies that have birth defects. Now, obviously, if we're going to ask a mother who has a baby with a birth defect, you know, did you take an aspirin? Did you go eat this or that? They're going to rack their brains for every little thing, thinking it was their fault that their baby had this defect. So we need to either, the group that we're going to compare it to is maybe another group of kids whose parents, whose babies have a defect, but not anything related to what we think is going to be the issue, and ask them that. Or we ask in a sort of a way that we get the mothers with kids who are healthy to have the same recall. It's difficult, but it can be done. Case control studies also are, we know the outcome at this present time, and we're asking about past exposures. Randomized clinical trials are going forward. We get a group together, we do an intervention, we find out what happens to them. So those are going in that direction. And as I said, cohort studies, you can have some that go in both directions. So I'm part of the Nurses Health Study, which is a famous cohort study in the United States. When they recruited me, they asked me a bunch of questions about, you know, what did I eat when I was a teenager? They still ask me those questions. I don't know why. But they also, every 2 years, ask me about things in the last 2 years, but going forward. So yeah, they can be either way. Okay. Okay, if we compare cohort to RCT, the similarities are we've got two groups. We follow people over subjects to monitor outcomes. We select the groups to be comparable. And we don't really, the groups may not reflect the general population because we've chosen them specifically to be comparable. And our statistic is the relative risk. The difference is random allocation of the exposure in the RCT, where it's self-selected in the cohort. Randomize the baseline characteristics. Baseline characteristics are randomized, so hopefully equally distributed. We try to choose our cohort carefully, but we have to adjust for the probable inequalities on baseline characteristics statistically. We use a placebo or match group experiences and mask the assignments in RCT, and in a cohort we select them in masking sometimes as possible, especially if you're assessing outcomes maybe, and time can be in either direction for cohort. Cross-sectional studies, they're fast and inexpensive to do. There's no loss to follow-up, which is great. You can assess many exposures and outcomes at the same time. They can be hypothesis generating, and they can be highly generalizable if you're using population-based data. In the United States, we have something called NHANES, where we ask, it's a nutrition survey that is a random, it's samples to be representative of the US population, so we can infer to the whole population. The disadvantages, again, we're not sure if the exposure led to the outcome or the outcome happened first. It's not practical for rare occurrences. And you have to remember that when you're asking people, the people who are going to be in your sample are going to be the healthier people. So it's sort of the healthy work or survivor bias. So you're not the people who had a really severe disease might have died very quickly and may not be in your sample. Since there's not a true denominator, it's an odds ratio instead of a relative risk. We're not going into statistics today. I'm sure someone else will discuss that. So as I said, observational studies usually in and of themselves cannot be considered causal, but all of us believe at this point that smoking causes lung cancer, but we've never done an RCT of it. And so there are ways that you can then build up the evidence. So several studies showing the same thing, showing that the exposure comes before the outcome, a large relative risk. So the relationship between smoking and lung cancer has a relative risk of about 10. So even if there's bias in the studies, you have to sort of think about how much bias would have to occur for that relative risk of 10 to go down all the way down to 1. A dose response relationship. So do people who smoke only 1 pack a day have a lower relative risk than those who smoke 3 packs a day? Yes. So there is a gradient. Is there biological plausibility? Yes, we did animal studies to support it. Is it consistent with our other knowledge? Have other alternatives been explored with smoking? Yes, nauseum. And if you stop the exposure, does it go away? And yes, if you stop smoking, your risk for lung cancer goes down. Specificity of association was one of the ones that Bradford Hill included in his criteria, but lots of things can cause different, lots of exposures can cause different things. So a lot of people have sort of bracketed that one. So, okay, so we have a research question. We conduct literature search. There's no gap. We have to go back and find a different research question. If there is a gap, we refine our question and we do a study design. If the focus is on individual values or experiences, it's a qualitative study. Little is known on the topic. Or doing an exploratory study, it could be a descriptive study, or it could be a qualitative study. And then we could do a confirmatory studies, which we've just been discussing. So briefly, you look at what your goal is, and you want to use the minimum of resources. So you decide which is better given your amount of money, resources, time, and the kind of effect you expect to find. And then once you know that, you have to make some more decisions about, are we going to do case control? We're doing that if it's a rare disease, long latent period cohort. Then if you're going to do a cohort study, then you are going to decide, do you have data that you can do retrospective, or do you have to do it prospectively? And then this is just a table that says, you know, gives you sort of an algorithm of the kind of study, if you're going to make comparisons or not, what are you going to do an intervention or not, what kind of study design it is. Okay, so can we do the poll now? If I stop sharing.
Sure.
So I just have some questions. People can answer these questions. This is the poll, so you select your answer, and you should be able to, there are multiple choice answers, so you just select whatever answer it is from that arrow, and then when you're done, you just push submit.
I'm urging everyone to please try it, even though it's
yeah, just try
do
just
something,
to generate some
discussion. To see,
and
yes, just take a shot at it.
No, there's no right or wrong, actually. There's, you know, I mean, a lot of them could be, some of them could be, there's no right or wrong. I mean, any of them are possible. It's a way to generate some discussion.
I think it's a minute now. We'll give it a few minutes. Great, we've got someone starting. Please, others. You'll only learn by taking chances. After that, you'll realize why you.
It's also anonymous.
Right.
Nobody knows what your answer is.
Exactly.
The reason I do it this way is nobody knows who answered what. Doesn't,
Great. Keep going. Others more. The more, the better. Mary, we've got 9 people trying it. Do you want to tell me when to stop the poll?
Yeah, you can stop anytime. It's fine.
All right.
And if you can show if you could just show the result.
Yeah, let me just share that now. It's fine. Okay, we've got 11 people who did that.
Okay.
There are the results.
So the first question is, which study design, what is the use of traditional and complementary medicine among HIV patients prior to initiating ARTs? So a lot of people chose cross-sectional, and that would be a very efficient way to get at this information, right? You could, and you could decide how you wanted to do it. If you wanted anybody who had HIV, you could have them if they were initiating, are you using it? If they're already on ARTs, they came to the clinic, you could ask them before you started. So it would be a very efficient way. Retrospective cohort study, that would be a little bit more difficult because you're trying to go back in time and look at some source of information about these people may have been thinking about asking people previously, did you use that, which would be a cross-sectional study because you're just asking once, right? Case control, I wouldn't really, this is, HIV is pretty common, use of ARTs are pretty common. I wouldn't probably use case control in this case because it's just a difficult way to do that. So I would say you could do cross-sectional. You could also, in this case, it limit yourself to people just initiating ART if you wanted to eliminate some recall bias. But if people are going to be open and they're going to be open, even if they already have HIV and using ARTs, you could say before you started, did you, and have your list of therapies there.
If I may quickly ask, Mary, basically the case control, the difficulty is around, can people be allocated to cases where they use both as opposed to, or perhaps allocated to using only HIV, transitional healing
so that
versus using both?
Case control studies, you would take only people who have HIV, right? And then you would take a group of people who didn't have HIV, and then you would ask, or who are using ARTs, and then you would go back and say, oh, are these people using complementary? I'm not sure how a case control study would work, actually.
Yeah. No,
it just
it's
sort of
just the technical difficulty of allocating them in terms of that particular thing.
And you're not choosing them based on exposure, but on the outcome. And so it would be probably not that informative. Sure. Okay, can you just scroll down a little bit so we can see question 2? So what's the association between blood pressure and serum uric acid among pregnant women attending a certain hospital? And if you could scroll down so I can see it, the responses.
So I think that you might have to do that yourself, because I don't,
okay, okay, maybe I can do it. Let's see. Oh, okay.
Yeah, you can actually
okay,
see
my mouse wasn't
results.
working. Okay, here, sorry. Okay, so prospective cohort study. Yeah, I mean, so you could do a variety of things here. This probably would not be experimental because this is just an observation of an association. But you could take a bunch of pregnant women and in the first trimester or whatever, draw their blood and their blood pressure, and then second trimester, third trimester. So that would be a way that you would have the same person, right, and control for that. So, or you could do a series of, well, it would sort of be like a series of cross-sectional. You could take whoever's there, draw their blood, take their blood pressure, and then look at what trimester or how many weeks pregnant they were, and then observe from that. So either one of those study designs you could do. Again, with the prospective one, though, you need to, if you're going to do it, you have to make sure you have that person A is going to come back, and that you're going to be able to get them when they come back and repeat and repeat and repeat. So there's loss to follow up you have to worry about. So if you've got a mobile population, people who don't attend regularly, then you have to think about, is that worthwhile to do? But it would be, in that case, you're not asking simply about the association, but what's the development maybe of high blood pressure during pregnancy versus just, a blood pressure at a certain time. But yes, either one of those would be fine. Can motivational interviewing with adolescents
So if I may,
improve?
Mary, the reason it is not quasi-experimental is that there's nothing being experimented in that situation.
Right, there's nothing, you're not introducing any intervention. There's no intervention, right? You're just doing blood pressure and uric acid, that's it. There's no intervention, so it can't be quasi-experimental. And this one is, can motivational interviewing with adolescents improve psychotropic medication adherence? So here we do have an intervention. So either an RCT or a quasi-experimental study would be very appropriate. If you knew that some place had motivational interviewing, you could possibly, if there could be a situation where you could do a cross-sectional, but mostly this is an intervention. So you want to do, you could have a bunch of adolescents, you could have what their adherence is, then you could do the motivational interviewing and see if they improved, and then they could be their own control, or you could randomize them to motivational interviewing or usual care. So those
Mary, if I can say that if you cannot randomize or control and blind, you effectively are landing up with a quasi-experimental if it's less than those 3 issues. Or do you think
not
that
all randomized trials are blinded?
Okay,
so,
sure.
Yes, randomization is random assignment is the key difference between
Right.
quasi-experimental and RCT.
Where
is
you
random
cannot randomize your participants. You're clearly lining up the quasi.
Yeah, but you might be randomizing the clinics that you put the MI in, right?
Of course, yes.
So you're randomizing the clinic, but not the individuals. So it's
Sure.
still considered quasi-experimental because you're not randomizing you're not random assignment to the individual, right? Difference. Okay, what are the environmental risk factors for Burkitt's lymphoma in Uganda? So Burkitt's lymphoma is a fairly rare thing. So in this case control study is probably your best bet. Now, apparently Uganda has the highest rate of Burkitt's lymphoma. So it's maybe possible that you could do a cross-sectional study because you might have enough cases in which to do that in Uganda. So a prospective cohort, I mean, first of all, it's such a rare outcome, even quote unquote, if Uganda has more cases than other people, it's still very rare and you wouldn't, and it's happens in childhood. I don't think a prospective cohort study would be a good use of time or resources for this. You know, I mean, if you had a lot of money, it would be great, right? If you had a lot of money, a place where a higher incidence, yeah, but it would be a lot of money and a lot of time to follow these children from birth to 5, 6, 7 years. You could do it, but it wouldn't be the most efficient, cost-efficient use of resources. Okay, and then the last question has to do with the difficulty in choosing our comparison groups in our observational studies. So if you want to study exposure to auto paint fumes increases lung disease, we identify a group of auto workers. Who do we choose as our comparison group? So a lot of people chose sample from the general population living around the plant. And that's our general instinct. However, if you're an auto worker, you have to be healthy enough to get up and go to work every day. And there's going to be a lot of people in the general population who are going to have disabilities, who are not going to be healthy. So it's what we call the healthy worker effect. So you want to get a group that also are workers probably. So, so the candy making plant, maybe, now the desk job people, do they have the same stresses, the same of being on an assembly line that the auto workers have? Typically the people who have the desk jobs might not be as comparable as people on another assembly line. Now there could be problems with this, I don't know, I made up the candy making plant, but you, again, you have to think about it, but I brought this up because of the healthy worker effects. You have to think about the general population is a mixture of people with disabilities and people who are healthy. So that's the end of that. I'm going to now,
should I stop sharing?
Any questions? Questions? I am going on a little bit longer than I thought. Okay, I'm going to talk a little bit about now, where did we go back to? Hopefully
I think you're on slide 27.
Okay, yeah, so, okay, this is your methodology section of your research proposal. It's straightforward to a certain extent. I'm going to just point out a few things. Be as specific as possible about your setting and your population. If you're going to have inclusion, exclusion criteria, be thoughtful about them. Only exclude people if essential. I was doing a study in almost homeless women, and I was going to say they had to have good mental health. But then when I'm writing my proposal, I'm thinking about how am I going to measure mental health? Do I really want to do that? If someone doesn't have good mental health, will they even be able to get through the informed consent document? Probably not. So I decided to just drop that because it wasn't that essential. So that's important. Some studies that are analytic, not necessarily descriptive, need a sample size. You should do that calculation early on in the process because that affects how many people you need to recruit. So your recruitment process, your setting you're going to choose, and your budget. So, and if you're doing a prospective study, you have to account for how many dropouts. So if you have to increase the size to account for dropouts. You need to talk about how you recruit. Are there privacy issues about recruiting and completing your questionnaires? Those all need to be addressed on how you're going to conduct your study. If you're going to ask your group to complete questionnaires, is it okay for them to talk among themselves? You know, probably don't want them to do that. If not, then you have to make sure you tell them that. So a study variable table is really helpful to your reviewers who are reviewing your grant. So if you put what are you going to measure in a table like this, where it tells you what are you measuring, and then if there's validity, reliability statistics, if you put them all in one place, that's usually helpful for people. I have a little bit on validity and reliability a little bit later on. The most common errors I see are definitions of how your independent and dependent variables are not matching your study aims. This happens to all of us. We're writing, and then we realize we're going to measure it. Oh, we're going to measure this. Now we realize if we use this measurement tool, oh, that's not in our aim. We have to revise our aims. So really, your study aims do get revised while you're actually writing up how you're going to do your study. That's just really common.
Martin, I want to go to the functions from
lack of specificity about recruitment and study procedures. So you need to be clear about that. And many times people's analytic approach may not match their variables. I see people doing correlations when they have categorical variables. So I'm not getting into statistics, so that they wanted me to talk a little bit about surveys and their administration. So the goal is to get the minimal amount of the data, quality data, to answer your question. So you don't want to ask things that aren't necessary. It's very tempting to ask a bunch of things and think, oh, I'm going to analyze that later. But really, if long questionnaires, you're going to get just garbage. So really be clear about that. So how do you develop your questionnaire? Well, Delphi study, like asking, experts to review your questionnaire, focus groups from your target population, and then to choose valid instruments. And this is available online, free PDF. But this is the website for consensus of standards of measurement instruments. So they have help you find different instruments to measure different things. They give you appraisal tools and checklists to assess the instruments. So I would really recommend using that if you are looking for an instrument to measure something. Validity has three different things. Face validity just doesn't make sense. Is it, are the questions measuring what you want them to measure? Just common sense. Face content validity. Construct validity requires several studies to see if the items all hang together. And then criterion validity is where this instrument is compared to some gold standard. So, is it measuring depression? So if it's a new depression scale, you have some gold standard, usually interview, right, with the people to see if it's actually measuring that. Reliability is measured different ways, test, retest. So you give the same questionnaire to a person on Monday and again next Monday and see if they get consistent results. Inter-rater reliability. So if it's something that two people are looking at, are they doing it the same, if they're coming up with the same answer, if they're looking at X-ray or whatever. And internal consistency is the validated for validated instruments only, and that's the degree to which the items are measuring a single concept, and that's usually reported as a Chromebox alpha. You don't really want too high, because that means then you got a lot of repetitive items. You don't want too low, because then they're not measuring a single concept. So you can have bias in all different phases of questionnaires: the design of the questionnaire, the questions, the design of the questionnaire itself, and when you administer it. So just use plain language, use simple language, use pronouns like you, active voice, short sentences, easy to read, like big font, lots of white space. Make it as easy as possible for your respondents. Wording, use consistent wording throughout. Don't change a word that you use. This is not an exercise in some literature, but avoid overly complex questions, leading questions such as you don't think that you must think, do you think that people who are in pain should be released from it during their dying process? Like really loaded questions, or double negative questions, okay? Such as a double barrel question is, do you think flu shots in short supply should be given to women and children first? Well, maybe I think they should be given to women, not children. Maybe someone else thinks children. Well, then don't ask both together, ask them separately, okay? Vague words are vague answers. How often do you exercise? Regularly, occasionally, or twice a week, or once a week? Okay, so be as specific as you need to be. Forced choices, make sure you have all the choices that should be available. Don't miss any intervals. Don't have overlapping intervals. So, and decide on the type of question you want, and and Likert scales are really difficult, because this middle one, what does it mean? Does it mean I don't know, I'm neutral? You could put I don't know out here so that you don't have that. So you have to decide what they mean. And remember, Likert scales are ordinal. They are not a continuous measure, so they should not be really analyzed that way. When I had this question in my study, the first researcher had put very satisfied as 1. Well, most people think higher is better. And a lot of people were choosing 5. And I thought they're very unsatisfied. Well, they just were seeing 5 as very satisfied. So I had to go back and change it. So, so make sure that you decide on what the scale is going to be. They're going to have open-ended questions, put them at the end, and you have to have a way to analyze them. Formatting can lead to inaccurate responses, so make sure it's visually appealing. I mean, this requires much more reading than this. If you're going to have something in lines like that, make sure there's a line or shading so people don't, answer this question down here, okay? Questionnaires are too long. If they're too long, people are just going to write all yeses, all nos, all ones, whatever. So you want to make sure, again, that the questionnaire is not too long. Sometimes people will not answer sensitive questions. So universalizing the question, like many women experience domestic violence. Generally, you put socio-demographic questions at the end. The most important questions you want answered should not be put at the end. Put them earlier in your questionnaire. And I don't know, I mean, most researchers on this call will say pretest, pretest, pretest. You need to pretest your questionnaire and ask the people pretesting it to write all over it. And you're going to get some interesting things. I had a doctoral student who was looking at what people eat and how much, and their breastfeeding. One person said to her on the pretest, well, you asked me about the herbs, but you didn't ask me about the foods I ate to increase my breast milk. So she had was able to have a whole nother section, and nobody else has really reported on foods before that. So pretesting is really important. So people do have a tendency to have bias. So that's why lots of questionnaires have positively worded questions and negatively worded questions. So you don't have people answering all 5s or all 1s that make them really read the question. If you are doing it verbally, then you need to be very careful about your body language, how you emphasize things, if you're reading to a population that can't read the questionnaire. Okay, so that's the end of this presentation. I'm going to just see if there are any major questions before we try to do our group exercise. Someone asked for the PowerPoint, and I will make a PDF of the PowerPoint and send it, and I don't know how that gets distributed, but I'm happy to do that. Any other questions at this point? Okay, I don't know how many people are, 26 people. Okay, so I'm going to make, I think, can I make the rooms? I'm not sure, but no more than 6 people per room. There are one, two,
we can break it out into 4 groups and make it, I think some people might fall off as well. So
okay, okay, so all right, so I have 3 exercises. So you can choose your room, but if there's more than, if we have 4 rooms, if there's more than 6 people in a room, you have to go to a different room. And then, let's see.
I think the problem may be that they will not know what your exercise is if they don't have.
So this is the room. I'm going to leave this up. Yeah. So
they will go into rooms and not have this available. So if you can take a screenshot and
okay, so can we agree what we're going to do? How about okay, room 1, let me just change this. Let's see if I can go out of here. Wait a second.
How long do you want to allocate to it? Because we've got, I think, less than 30 minutes.
I was going to give 15 minutes. But let me just change the room numbers. So if we have, okay, so we'll do room 1, 2, and 3 and 4, and then they can take it.
Yeah.
All right, so, okay, so now let me just share that. Yeah, so if you can take a screenshot of this, can you see it? It's not in the, let me put it. Oh, shoot. No. Well, I think it's best if I just do it not that way.
If you perhaps do this, I will take a screenshot and then share it. Just put it up and I will put it up in the group.
Yeah, I know, but the problem is it just jumped to, I have to go back. It just jumped to, it just jumped to the beginning. So I got to go back here. Oh no, I got to go back here. It's not
I think if you just click If you open the slide and then just move it to the last.
Okay. This way, here. Okay, and then I'm going to share this. Okay, so what I'd like you to do is I have some questions under each of these questions. These were actually, I took from some of your proposals that you sent in. So maybe it will help somebody. And just go into a room and think about the different designs, how they might, with these questions in mind. And we have about I'm going to give you about 15 minutes. That will give us a few minutes to report back. So I don't have the time on my computer is not showing up.
It's in the group, it's in the chat already. So if you click on the chat, you should be able to open the screenshot of this thing, of this slide. And I think you'll be able to get it when you get into the group as well. So I'm going to open the groups and you can then join the groups and we'll count for 15 minutes exactly. So please join it. And I'll also drop into each group and see if I can provide you the documents. Okay.